In this talk, I'm going to be telling you about fetal transposition of the great arteries. I aim to assist you to make a diagnosis prenatally of transposition of the great arteries and to give you pointers to make an estimate of the postnatal condition of the baby. Transposition has an incidence of about 5 per 10,000 live births and makes up about 6% of congenital heart disease. It is usually divided into simple and complex cases. The simple cases have an intact interventricular septum, and the complex cases may have an additional lesion such as a large VSD, pulmonary stenosis, or coarctation of the aorta. It is important to understand the hemodynamics of transposition of the great artery in the fetus. If you look at the diagram on the left side, you will see the normal fetal heart and the saturations of oxygen in the different compartments. You will notice that in the ascending aorta, the oxygen saturation is 65%. However, in transposition of the great arteries, it is 60% when there is a ventricle septum defect, and it is 50% when the interventricular septum is intact. You will also see that in the normal heart, the saturation of oxygen in the pulmonary artery is 55%, and it is increased to 70% in transposition of the great artery because the pulmonary artery is located above the left ventricle. As in the normal heart, there are essential shunts that are very important in transposition of the great artery, these being the ductus arteriosus and the foramen ovale, which we will speak more about in the rest of the talk. This is the situation postnatally. You will see that oxygenated blood comes from the lungs, returns to the left atrium, to the left ventricle, and then via the pulmonary artery is returned to the lungs. So oxygenated blood does not get into the systemic circulation. This is a condition not compatible with life unless we have two shunts open, and those are the foramen ovale and the arterial duct. So this is a critical heart defect that is ductal dependent. The prenatal diagnosis of transposition of the great artery has been associated with reduced mortality and morbidity, earlier balloon angioseptostomy, and less mechanical ventilation preoperatively. In our study of transposition in the Amsterdam-Leiden area, we found a reduced first-year and pre-surgical mortality and reduced indicators of pre-surgical morbidity in our group of transposition patients that were diagnosed prenatally. Our aims of prenatal diagnosis then are to try to prevent the image that we see in this picture. A baby that presented with multi-organ failure requiring ventilation in intensive care. To do this, we need to make a precise anatomical assessment. We need to be able to predict the neonatal condition so that appropriate peripartum planning can be set in place to optimize outcomes. Generally speaking, the diagnosis of transposition of the great artery has had low detection rates worldwide. In 2007, we started a national screening program for congenital heart defects in the Netherlands. And in the 5-year period before that, our detection rate was 16%, and in the 5-year period thereafter, it had increased to 41%. In this screening program, it was obligatory to include the 4-chamber and the outflow tracts. So this showed us how important it was to have the outflow tracts as part of your screening program. We can see in the middle image the left ventricle leading to a vessel that divides, that is the pulmonary artery, and we can see in the image on the right the parallel arrangement of the great arteries. It is thus important that the congenital heart defect we are looking for is visible in the views we use. It is also important to use a 3-vessel and trachea views when detecting transposition of the great artery. On the left side, we have a normal 3-vessel view where we see the pulmonary artery, the aorta, and the vena cava superior in a nice line. And we see that the size is descending from pulmonary artery to vena cava superior. On the right, we have a normal three-vessel and trachea view. We can see the ductal arch and the aortic arch coming together on the left of the trachea, making a V sign. In transposition of the great arteries, you can see that the three-vessel view is different. This central vessel is splitting. On the right, although it is a bit of a difficult video, you can see that the central vessel is dividing in two and then continuing as a ductus. So this is transposition of the great arteries. On the left, we have a three-vessel and trachea view that shows the normal V sign. And on the right, we have a baby with transposition of the great arteries. And you will see that there is just an aorta visible and the pulmonary artery does not come into view. We're always looking for easy ways to remember how to diagnose things. And so the findings on the three-vessel and trachea view have been described as a boomerang or as an eye. And in Japan, there is a comic figure called the big-eyed frog, and the findings on stick 4D volumes has been described as a big-eyed frog sign. This is because the pulmonary artery and the aorta come out of the heart in parallel, and so you can see two round structures, which are the eyes of the frog. We can also see this on the short axis cut of the heart, where normally we only see an aorta as a round circle with the pulmonary artery arching over it. In the postnatal cardiology, we call this the sunglasses sign of transposition. And if you come from South Africa, we call it the double-barreled shotgun sign. When looking at the three-vessel and trachea view, it is important to realize that when you only see one vessel, you may not necessarily only be dealing with a transposition of the great arteries. You can get this sign also when you have complicated double outlet right ventricle with malposition of the great arteries, with a small pulmonary artery or pulmonary atresia, in the case of common arterial trunk, and if you have pulmonary atresia. Should this vessel here be a duct and not an aorta, then you may be dealing with aortic atresia, hyperplastic left heart syndrome, or interrupted aortic artery. When we scan, we're looking in 2 dimensions, but it is also a good idea to try to imagine how your heart would look in 3D. So here we have a model of a normal fetal heart, and you can see that the areas of the heart have been coded with color, so that the aorta is in red, the duct in green, the left ventricle in green, in darker green. And this is transposition of the great arteries. So we can see here that the aorta is anterior and above the duct, and that's also part of the reason why we don't see it on the three-vessel and trachea view. Here we have a section through the level of the three-vessel view on a model from a 4D volume. Here you can see the pulmonary artery, the aorta, and the vena cava superior in a normal line. This is an example of a transposition of the great arteries. Here we see the aorta to the right of the pulmonary artery behind it, with on the right of the pulmonary artery the vena cava superior. And we see that the central vessel is. Here we have cut through our model at the level of the three-vessel and trachea view. In the normal heart, we see a pattern that we recognize, with the duct and aortic arch coming together on the left of the trachea. In our transposition heart, you can see the cut is going through the aorta, but we only see 2 vessels because the duct is underneath and not visible. In 2012, the 3-vessel view was added to our national screening program as an obligatory view. And our detection rate for transposition of the great arteries improved from 44% to 82% before and after the introduction of the 3-vessel view. Once again, emphasizing the importance of these views in your diagnosis of transposition of the great vessels. So now we have learned how to recognize transposition. But once we have recognized it, what else is important? We also need to know if we are dealing with a case with intact ventricular septum or if there is a ventricle septum defect. Should there be a defect, we need to know how big it is and if it is possibly malaligned. We also need to know if there's any obstruction to the outflow tracts, as can be seen in the example of the videos. We see turbulence across a small pulmonary artery. We also need to know the valvular morphology, the size and spatial relationship of the aorta and the pulmonary artery, the presence, size and flow in the arterial duct, and the patency and size of the foramina file. Why is this important? It is important because it tells us what will happen when the baby is born, and this is extremely important for counseling and also for the planning of the perinatal management of the baby. We need to think about whether a Rashkin procedure will be required as an emergency after birth. We need to think about which operation the baby will have and if the baby can have a biventricular correction or if it will have to follow a univentricular path. Postnatally, the foramina file closes functionally. On around the 3rd day, the arterial duct closes. So we need to give the baby's prostaglandin to keep the duct open. In some cases, we also need to increase the opening between the atria. This we do with a Rashkin procedure, and this is shown in the video. We pass a catheter through to the left atrium, inflate a balloon, which we then pull back into the right atrium, creating a defect between the atria. The question then arises, can we predict the need for a Rashkin procedure prenatally? We've been trying to do this for some time and unfortunately are still not very good at it. However, you have an increased risk of requiring a Rashkin procedure if you have transposition of the great artery with a flat septum, as shown in the bottom middle image. Above that, we see a hypermobile aneurysmal foramina file flap, which may also be associated with an increased risk of Rashkin procedure postnatally. We can also measure the size of the foramina file, work out its ratio to the total septal length, and look at the excursion of the foramina file flap within the left atrium. It is very important to do these evaluations as late as possible in the pregnancy, as the anatomy of the foramina file changes through gestation. We can also use other parameters. We can look at the pulmonary vein flow. An S wave greater than 40 centimeters per second is associated with an increased risk for Rashkin procedure. It is important that we look at the arterial duct. We need to see if it's open, and should we see reverse flow in diastole, this can be a predictor for pulmonary hypertension postnatally. Currently, some units are giving maternal hyperoxygenation in order to determine the postnatal condition, where a change in the pulmonary artery PI of less than 15% is associated with pulmonary hypertension postnatally. An increase in the middle cerebral artery PI is associated with increased risk for emergency Rashkin procedure, and foramina file less than 3 millimeters during maternal hyperoxygenation is associated with the requirement of a Rashkin procedure postnatally. Pulmonary hypertension can occur in transposition of the great arteries postnatally, and when present can be devastating. Here we have an example of a patient who at 18 weeks showed a relatively normal looking 4-chamber view. By 26 weeks, we can see that the left ventricle and the left atrium have become dilated, and we see the foramina file flap bulging over into the right atrium. This is the same baby at 30 weeks gestation, and we can see a very restricted possibly occluded foramina file and dilated left atrium. And we see also that the duct is virtually closed. We only see a small little turbulent jet in the arterial duct. Because this baby had other problems, the parents decided on a non-active management, and this baby breathed one breath and then died. For such a case with arterial and foramina file obstruction, the only hope for survival would be to put the baby on ECMO immediately. And for other cases of pulmonary hypertension, management with nitric oxide postnatally is required. And so it's handy to have some kind of an idea that this may be necessary already prenatally. We now come to the options for surgery in transposition of the great arteries. The first choice is an arterial switch operation. In the arterial switch operation, the great vessels are divided above their valves, and the vessels are swapped. The coronary arteries are taken with the aorta. This means that the pulmonary valve remains attached to the left ventricle. In the situation of pulmonary stenosis, an arterial switch operation is not possible, and the options then are an Aikido or a Rastelli operation. In an Aikido operation, the valve and the vessels are swapped around, and the obstruction of the right ventricular outflow tract is corrected. In a Rastelli operation, depicted on the right at the bottom, the VSD is used to make a conduit from the left ventricle to the aorta, and this takes up some of the right ventricular space. The right ventricle is then connected to the pulmonary artery external from the heart, and so the pulmonary stenosis is corrected. It is important that we know when an arterial switch will not be possible so that we can counsel our patients correctly. The major reason for not being able to perform an arterial switch is because there is left ventricular outflow tract obstruction for whatever cause, but predominantly this is because of pulmonary valve stenosis. It could also be because we have straddling of one of the AV valves, or that there's hyperplasia of one of the ventricles, mitral valve abnormality, or anterior deviation of the coronal septum. Detecting the degree of pulmonary stenosis prenatally can be difficult. In this example, we can see that the velocity across the pulmonary artery is about 100 centimeters per second. But this does not tell us anything about the degree of pulmonary stenosis because the distal pulmonary bed has a high vascular resistance. So we have to be guided by the size of the pulmonary arteries. And in this case, we can see that there is retrograde flow in the arterial duct. This retrograde flow in the arterial duct tells us that this is a significant pulmonary stenosis and that this case is not suitable for an arterial switch operation. So this case would then have to have an Aikido or a Rastelli operation. When you are considering that a Rastelli operation is going to be required, it's important to see the space that will be taken up by the left ventricular to aorta tunnel, which will be required in the surgery, and how much of the right ventricle is left over, and if this operation will be possible. Here we have an example with straddling of the left AV valve. We can see the chorda extending across into the right ventricle. So in this case, an arterial switch is not possible. So I'd like to conclude with the last case, where at 20 weeks we see some left ventricular and right ventricular disproportion. We see a bicuspid valve. We see a small pulmonary valve, but a reasonable pulmonary arteries, and we see turbulence across the outflow tract of the left ventricle. At 32 weeks, we can see that the disproportion between the ventricles and the atria is more prominent, and we see that there is some accessory tissue on the mitral valve. These are the postnatal images of that baby. Here we can see that accessory tissue on the mitral valve making the picture of a heart in a heart. In the middle, we see the outflow tract of the left ventricle with turbulence across it and a high gradient because of obstruction of the left ventricular outflow tract caused by that accessory tissue. So in this case, an arterial switch was not possible, and this left ventricle did not grow sufficiently, so that the patient eventually ended up having to have a Fontan operation. And so we come to the take-home messages. Remember that in fetal transposition of the great arteries, there's reduced cerebral oxygenation, and this has implications for the prenatal and postnatal development and course. There are 2 essential shunts that need to remain open prenatally and postnatally until the arterial switch is performed. This is the foramina fili and the arterial duct. We hope by making a prenatal diagnosis to be able to provide better perinatal management and reduce mortality and morbidity. To do this, we have to make a good diagnosis using the outflow tract views, the 3 vessel and trachea views, and the sagittal views. We should try to predict the possibility of a Rashkind procedure, and it's important to comment on the size, presence, and location of ventricle septum defects if present. Beware of accessory tissues, AV valves that are straddling, and any non-cardiac pathology that may be associated. If pulmonary stenosis is present, try to assess severity based on the flow in the duct, the absolute size of the pulmonary valve, and the pulmonary arteries. Try to assess ventricular size. It can be difficult at 20 weeks. Be careful when there is early disproportion. In presence of pulmonary stenosis, remember to consider the space taken up by the Rayleigh tunnel and its effect on the size of the right ventricle. I thank you all for your attention.